I will talk about biological options for optimization of aneurysm healing. And first of all, we are not just brain plumbers. We know that for interventional neuroradiologists, the aim is to occlude the arteries or reopen arteries, but we are not just brain plumbers. And biology is the key factor specifically for aneurysms. We can see that if we have an aneurysm, it's just because there is an aneurysm arterial wall disease with less of smooth muscle cells. There is a rupture of the internal elastic lamina, and the media is very thin. And there is an imbalance between growth repair of the arterial wall and degradation and destructions due to aberrant hemodynamics. So these biological facts can lead to thrombosis into the aneurysm sac and also proteolytic activity, which means that it could lead to a rupture. I'm sorry. So, and we still are plumbers, either if we go with clip or even when we go with stents or coils, we just want to occlude the aneurysms, but we should more focus on biological aspects of our treatment. Here we have the representation of an aneurysm, which is the pathology is the aneurysm wall, but the artery should be normal. And we can see that when we use a clip, there is a realignment of the normal artery. But then when we are with coils, we don't treat the diseased artery. And that's why probably we should observe coils compaction and recurrence of the aneurysm in up to 40% of cases. The process of healing after coil aneurysms takes a little bit of time. In the first 7 days, there are some fibrin at the level of the coils, and also you can see here in purple, there are some macrophages. And then there are mesenchymal stem cells here in green coming into the sac of the aneurysms and progressively fibrosis into the aneurysms, well, 1 month later after the treatment. And what we hope to have is a neoendothelialization at the level of the neck. Unfortunately, in ruptured aneurysms, there are very, very few cells in the aneurysm wall. And since there are few cells, there are few smooth muscle cells that could invade the aneurysm sac, and that's why ruptured aneurysms are more prone to recurrence than unruptured aneurysms. Here on the first line, this is the schematic representation of an unruptured aneurysms, and here the schematic representation of ruptured aneurysms. So this is what we can see here also. When there is a healing process, it's because of mesenchymal stem cells that could invade the aneurysm sac. But when there is not enough cells, that could lead to recanalization. This was done by the Jean Raymond's team in Montreal in a dog aneurysm model. So if there are few cells in these aneurysms, we can hope to add cells, and the cells which are involved are mostly fibroblasts, smooth muscle cells, endothelial cells, but we can also hope to add stem cells which can differentiate in those 3 different types of cells. If you want to add cells and do a cells treatment, you can use either heterologous cells, which means from one species to another species, homologous, which means from one individual to another individual of the same species, and autologous, which means your own cells for your treatment. You can also use different administration routes for cells, either intravenous, intra-arterial, directly intra-aneurysmal, or what we call bioengineering, which means you put cells on coils or stents. So different studies try to analyze this, the results of using either vascular smooth muscle cells, fibroblasts, endothelial progenitor cells, or mesenchymal stem cells in models, mostly in rabbit models. This is this elastase model in rabbit we use here in Limoges. We create surgical aneurysms, a surgical incision of the right common carotid artery at the level of the neck of the rabbit. Then we introduce a 5 French introducer, and we infuse elastase in this common carotid artery. And 3 weeks later, after ligation of the artery, we can observe this kind of saccular aneurysms, which are really close to what we observe histologically in human aneurysms. This is what we have here with a thinner media than in normal arterial wall. So some studies used the fibroblast. Here, the team at Mayo Clinic used fibroblast quite a long time ago, and they observed much better occlusion of those aneurysms. But unfortunately, using fibroblast can lead to procoagulant effect, which means that there is a risk of clotting at the level of the aneurysm treatment. Then you can use smooth muscle cells. You remember that there is less smooth muscle cells in the aneurysm wall than in normal arteries. And Marbache et al. Published a study in rats using smooth muscle cells in treatment with fibrin. So they have some kind of sponge with fibrin, and they added smooth muscle cells in it, and they observed much better results at the level of the neck. You can see here that there is neoendothelialization with endothelium and collagen here at the level of the neck. Some other used smooth muscle cells in gel form sponges with fibrogen, and they observe also greater results of healing. You can also use endothelial progenitor cells. There are those cells which could differentiate then in endothelial cells. The problem with using endothelial progenitor cells is that there are very, very few cells in the blood, and this is very difficult to extract them from the circulating blood. But you can observe in models a better occlusion of your aneurysms. Maybe if you want to replace smooth muscle cells, fibroblasts, and endothelial cells, the best option is to use stem cells because they can lead to tissue recanalization, and they have this pluripotent effect, which means that they can differentiate in the smooth muscle cells or endothelial cells, also fibroblasts. And they have a paracrine effect, which means that those smooth muscle cells, those stem cells, can secrete some tissue factors, and they can promote neoendothelialization. So using stem cells can lead to a better balance and improvement of the extracellular matrix synthesis and degradation, and also with the paracrine effect, there is less macrophage infiltrations, less inflammation, and also those enzymes like metallopeptidase or metalloproteinase could be reduced thanks to the bone marrow mesenchymal stem cells. So this is something we did quite a long time ago in Paris using autologous stem cells in rabbits. So we take bone marrow from the femur of the rabbit, and then we extract the bone marrow stem cells, then proliferation, and we implant those cells through a microcatheter directly into the aneurysms. We use a balloon inflated at the level of the neck of the aneurysm, and we observed a much greater occlusion rate in this group treated treated with bone marrow stem cells compared to the control group. So there was much less recurrence and volume of the aneurysms. Unfortunately, when we deflate the balloon after this first implantation, we saw that there were lots of cells going out of the aneurysm with an maybe ischemic risk, but also the risk of not being efficient at the level of the aneurysm. So we decided to use bioengineering. We used some kind of hydrogels, spherical hydrogels that we did with polysaccharides, which means this is with no effect on the patients, but it could help to stabilize the cells into the aneurysm. And we used porous polysaccharide microbeads. You can see here that this is deshydrated and this is like sponge, and they can absorb the mesenchymal stem cells. So we used this kind of delivery, and we observed a much greater increase of local cells delivery. Unfortunately, the risk with using those microbeads, that there is a risk of migration of the microbeads, and for sure there is a risk of ischemic complications. So if we use this kind of therapy, we should probably maintain them into the aneurysms with stent or flow diverter. Another option, which has been developed by the Toronto team with IDB, is using homologous bone marrow mesenchymal stem cells in rabbits. And they put first coils into the sac of the aneurysm, and then 5 million cells into the aneurysms after first coil. They obtain much greater healing of the aneurysms. The problem using homologous instead of autologous cells is that there is a risk of reject of the graft in human. So you should need to use immunosuppressive treatment, which is probably not an option for aneurysm treatment. But they observed greater healing. You can see here the thickness of the neanderthalization compared to control. So there is a great impact of this technique. When I was at Mayo, we worked with adipose tissue mesenchymal stem cells in autologous fashion, which means that we use cells from one rabbit to treat the same rabbit, and we coated the stem cells directly onto coils. We used axiom coils, and you can see here that we culture the cells on coils, and then we implant those coils into the aneurysm. We can see here, this is the control group on the right side. There is absolutely no tissue at the level of the coils and no immunohistofluorescence. But if we go to the treatment group, that you could see this neo tissue covering the coils, and also at the level of the neck, there is a neanderthalization, which means that there is a better healing. Also, you can see fibrosis here in purple with the mesentericum colorations, which means that there is fibrosis into the sac of the aneurysms. And we can see here, we did the quantitative measurement of this fibrosis, and we observed about 80 times greater fibrosis in this group, MSC group, compared to control. So this is great fibrosis, but what we can see here on the angio treatment, you can see here the control at 1 month, and there is a little bit of neck remnant, which means that the healing is such great that there is fibrosis of the coils, and that we observe this recurrence at the level of the neck in about all rabbits, which means that fibrosis can lead to this kind of neck remnants. But first observation is that cells therapy significantly improves histological healing. It improves neck endothelialization and collagen matrix formation. This could be a promising strategy for optimization of intracranial aneurysm treatment. And this is done in lots of other pathology. If you go to hematology, all patients have cells therapy. It means that personalized medicine for intracranial aneurysms is not something which is totally out of a dream, and we could probably go to stem cells treatment for aneurysms. Maybe also we can use some biomimetic peptides. These are some perspectives, but one of my dreams is to use some kind of polysaccharide gel or foam, like shaving cream, which could inflate inside the aneurysm and delivering some cells inside the aneurysm to improve the healing. We have many options for these biomimetic options, using either proteins, cells, growth factors, and other molecules. This is something which has been extensively reviewed by Zoltán Szatmári and will be published quite soon. For his research in Limoges, he used some polysaccharides which have potential to increase the tissue factors inside the aneurysm, and he uses this on coils, and we observe great endothelialization. One other limitation of our treatments is regarding flow diverters outcomes. We all know the healing process after flow diverters, which are really great tools for our treatments, but at 6 months after implantation, we still have 24% incomplete occlusions, which means there is room for improvement of these devices. Also, morbid mortality is not so low, with 9 to 10% morbid mortality, with 3 major risks, which are thromboembolic risk, collateral arterial occlusion, and delayed aneurysm rupture. This is not a rare issue if we consider greater than 10 millimeter aneurysms, because it can occur in about 2% of cases. The healing process of flow diverters is through a neo-endothelialization and coverage of the metal device at the level of the neck. But this process can take time, because at 3 weeks, we just have a red clot trapped into the aneurysm, and then only there will be a neo-endothelialization at the level of the neck and progressive fibrosis into the sac of the aneurysms, which can take up to 6 months in rabbits. And this healing process comes from the normal artery. There will be proliferation of endothelial cells here in green at the level of the neck, covering progressively the ostium of the aneurysms. But we still have 24% incomplete occlusion at 6 months, which means that we need to increase and accelerate endothelial cells proliferation. If you look at the industrial options, they say maybe more metal would lead to better occlusions. And they develop lots of new flow diverters and many others. This is the industrial point of view. I will use more metal, so I will increase my occlusion rate. This is probably not true, and probably the best option is to have a great wall apposition. If you don't have a great wall apposition, which means higher radial force, you will not lead to occlusion of the aneurysms here. There is no good wall apposition, and there is still a remnant. Here, if you have a good wall apposition, so that we can see here in histology, you have the total healing of the aneurysms in this rabbit study, and this was a 16 and greater odds ratio. And OCT is probably one of our tools to improve this wall apposition. And the conclusion of this article was wall apposition is more important than pore density for aneurysm occlusions, which means that higher metal level will not lead to better occlusion. If we look at delayed ruptures, there is this risk of huge thrombosis into the sac of the aneurysm, and we can see here delayed rupture with absolutely no neck at the level, no arterial wall, which means that this aneurysm wall is totally ruptured due to this active thrombus. When there is no total occlusion between the blood flow and the intraluminal thrombus, there will be neutrophils coming through this intraluminal thrombus trapped into the aneurysm, and there will be an increase in elastase, myeloperoxidase, and myelopeptidase, and all those enzymes will disrupt the aneurysm wall, leading to the risk of rupture. So how to switch from active clot with red and very active, like delayed bomb, to a healing thrombus with fibrosis and very passive thrombus. Some of us, and this is probably what most of us do, we adjunct coils for large aneurysms. This is an option given by industrial. But in fact, when we look at delayed ruptures in the literature, there was associated coiling in more than in about 18% of cases, which means that adjunctive coiling doesn't prevent delayed rupture in all cases, and the option is to inhibit neutrophils activation. So the ideal flow diverter should have fast healing with accelerated proliferation and endothelial cells and smooth muscle cells. It should have anti-thrombotic properties and anti-neutrophilic properties. Here is a work that we did with Jonathan Cortez in our lab in Limoges, using the CD31. CD31 is some kind of protein at the level of the endothelial cells, which confers all those properties to normal vessels. If you have a normal vessel injury, this will be fast healing. There will be no thrombotic activation and no neutrophilic activations. So if we put CD31 at the level of the stent, maybe we could prevent this activation. So this is what we did. We used the mimetic of CD31 and we grafted it on silk flow diverters in order to favor fast cells proliferation over the device and inhibits neutrophilic and platelets activation. And we observed a much greater endothelization, much faster at 1 month in rabbits. We observed also a greater endothelization at the level of the neck, and we observed this elastin and collagen proliferation over the device for safer healing. This is also what we have here. The neo-endothelization at the level of the neck is much more organized. This has been very recently published in Stroke with Jonathan Cortez and Bart. So in conclusions, for this second options, PI-TER-I or CD31 favors endothelization. It prevents platelet aggregation, prevents neutrophilic activation, and in fact, it transforms the flow diverter in an active barrier similar to normal artery. So for sure, we need larger studies before going to humans, but it shows the interest for maybe other devices also, such as coils or maybe web device. If we talk about web device, the healing process is quite similar to coiled aneurysms, but an observation which is maybe considered as a limitation of web device is the web shape modifications. We observe sometimes modification of the shape of the web device between treatment and control, but without any recanalization at the level of the neck. Some consider that it should be the water effect going onto the device, but maybe this is just due to fibrosis. If there is this healing retraction, as we saw in our rabbits with smooth muscle cells, there should be some retractions, which means that there is a very great healing, but the modification shape of the device. So we are currently trying to understand this mechanism of web shape modification. This is something with histology, so we will compare histologic results with web shape modified aneurysms and with non-modified aneurysms. This is done with Kevin Jano in our lab with Professor Mounier, and we can measure the web shape modification and understand that this is due to retraction and great healing. So we all see new devices every month, every year. We have lots of new devices. We should be very aware about those new devices. Is it still innovation? Should we take all those devices just to try new device, new tool? We are very excited with new tools, but we should be very careful about this. One of the greater options should be to consider the biological options. We need to stimulate innovation, and I think this is a very personal point of view, but if we want to innovate, we need to focus on healing and we need to focus on biology. There is a huge necessity for experimental research before going to human, and this is how we can go to definite proof and clinical proof. We need for this to have models. All models are wrong, but some are useful. And if you don't do models and don't try, if you have a great idea, you should try, and maybe sometimes we'll have new options for our treatments. Maybe we will have some medications for treatment of aneurysms. The key for device innovation is persistence, persistence, and persistence. We should never give up to find new options, not only led by industrial, and doctors have a great place to defend in INR research. We all have a role to play. We are not just plumbers, and creativity will be the key. We should work with biologists, physicists, and other specialties in a proper environment. So this is time for some advertisement for our platform in Limoges. And thanks to Professor Mouneyer, we have the great opportunity to have this new platform just opened 6 months ago. This is the EMIS research platform for experimental medicine, imaging, and surgery. So in Limoges, France, we have a good laboratory practice label. And everything is done for doing research either in pigs or rabbits. And we can see that they have this new Icono system. So this is the last angio suite from Siemens. So we can do with this, OCT scans, we can do 3D, 4D. And if you have any project to do either with aneurysms, AVM, or any other topic coming from your creativity, you're very welcome. And we would be very happy to share this with you. So thank you very much.